Hi, good evening, everyone. Welcome back to our another session of webinar, which we have on every Wednesday by Beating Hearts. And I'm Dr. Betty Tay. And I'm so glad that so many people are joining us still, despite the Olympics. I'm glad that it's not the day that they're playing badminton. If not, we would not have any viewership. Uh, that was quite interesting, our matches. And then without further ado, I'll introduce you my colleague, Dr. Mathi Arasu, who is also with me in Beacon Specialist Center, but he's practiced mainly in his own center, which of course he will explain later. Okay, Mathi, you take over.
Oh, all right. Okay. Yeah, thank you, Dr. Betty, for the opportunity. I'm not sure how when you ask me to give a talk, it's not easy. It's I mean to know what kind of a presentation that I'm going to do. But when you mention mainly, I'm going to speak to the primary care physicians, then I'm just going to kind of talk about the basics of fertility rather than going diving deep into the details of IVF or fertility treatment, because I think primarily everybody should have the strong basics in fertility and issues related to fertility. So let me start sharing the screen here. Yeah. Okay. Can you see the screen now? Yeah.
Yes.
Right. Okay. So I work mainly in an IVF center. It's called Everling Fertility Center, but I'm not going to talk about IVF. Basically, what I'm going to talk about is what is infertility. I mean, a lot of people talk about inability to conceive, but just because you've seen a 39-year-old coming to see you doesn't mean she may have a fertility issue. But at the same time, you might be seeing a 25-year-old with significant fertility issues. So sometimes we label fertility based on women's age. I think that is totally a wrong stigma. And I'm going to go further. 1 second. Yeah. So the infertility, I'm just going to give an overview. And how do we going to maximize our fertility potential? The question many people talk about nowadays is, when you see somebody with fertility issue, they need to go undergo fertility treatment, but it's totally not the concept. When you see someone for the first time, it might be a couple, and you do not talk about fertility treatment until you have done the minimal basic needs. And for what you know, they might just not lucky yet. Doesn't mean they should undergo fertility treatment. At the same time, you might be seeing a couple at the first onset itself, they got a big fertility issue. That's one. Two, fertility, when you talk about infertility, of course, it's the inability to conceive, but I think it goes beyond that. Nowadays, we see a lot of young women coming for egg freezing, so that is also a part of fertility treatment, but we don't call them infertility because they're not trying to get pregnant, but they may already have some issues when they are single, and you do not want them to go through a partnership and then realize that they might need fertility treatment. That's where the more recent concept of social egg freezing and so on comes in. So be aware that a couple may have a fertility issue, but doesn't necessarily it must be a couple. Could be a single man or single woman. So what is a primary physician's, general practitioner's role at primary care when it comes to fertility? I think you must be equipped with basic fertility knowledge. Now, I still remember those days when I was a houseman or MO, I used to do locum in GP clinic. They always tell me, when you see a gynae problem or you see a child, don't waste time. Just refer them to a hospital. Why? Because it's always complex. When you see a child, there's a lot of things in depth that we do not know. And also, of course, child have a lot of anxiety among the parents. And two, when it becomes fertility, a lot of people are complicated, that we need to do a lot of things, or we need to be equipped with a lot of knowledge. But I can tell you, fertility is terribly simple. When I say terribly simple, meaning you have just minimal basic information. But sometimes it can be terribly difficult or simply terrible because, they have so much complicated problem. But then all you have to know is you are not going to manage these terribly complicated problems because they are not within our resources, to manage this. You just have to know the basics of fertility. So let's go into the simple approach. Of course, you need to know a few questions to ask. You can't be sitting there and let the patient tell you. 90% of patients won't come and tell you, doctor, I have a problem with fertility. 90% of these patients will come and say, I got irregular problems, and then you go and ask further. They might be wanting to have a child for the last couple of years, or the husband may already have some issues, and they do not want to bring up the husband's issues. So sometimes it has to be a directed question. So very simple in approach. You have to have a few questions in your question banks when you see some women in their reproductive age group, and you need to know what are the causes of male and female fertility. You don't have to know the textbook, you know. The problem with most people is they go into the depth and forget about the basics. So we're going to go in the reverse. We want to go and strengthen our knowledge in the basics. Don't worry about the details, because details are beyond our management. And you need to know what are the investigations that you would like to know that you can do it in your practice. And also what you can do, not necessarily what is available. For example, not many centers are available with a lot of ultrasound scan. But nowadays, GPs minimum requirements to have a bedside ultrasound scan machine. Now I see a lot of them are having an ultrasound scan compared to 20 years ago. You know, so I think there are certain things that you know that you can do at your level and available. And the last thing that you should be able to manage is, when is the timely referral being done? You don't want to refer them too early and label them as infertility. At the same time, you do not want to refer them too late, where you already exhausted their resources, especially for female. Women's age is the essence, you know. So if you delay, the longer you delay women, the older they get, the lower the chance despite IVF treatment. So timely referral improves the outcome. The three things I summarize, you know, I know a lot of people preach a lot of different things. Listen to them, listen to me, and take what is you think is appropriate in your practice. I think we are all, you know, be a student, you know, you just want to catch whatever that makes sense in your practice, you know. Let's go with the first thing that everybody should know. Don't forget the male, because men contributes 50% of the fertility problem. So men and women contributes to each other almost equally. Never always label fertility issues for women as a women's issue, because of course women are most important person when it comes to fertility treatment, because their age, their prognosis are based on women and their age. But however, men, all they have to do is one simple test, semen analysis. So you have to just do a semen analysis. All you have to do is, whenever you see a couple, you're not sure, it's not wrong to tell them in the first instant, go and do a sperm analysis. It's called semen analysis in short, and you have to do it in a proper way. Don't send to a biochemistry lab. I see a lot of semen analysis being done in some labs like Innoquest, Path Lab, you know, DNA lab, but they are all biochemical lab. They are more probably genetic lab. They are not IVF laboratory. Therefore, the way they analyze sperms are totally different from an embryology assessing the semen. So that's why it's very important to do the test at the right place. Doesn't matter which IVF lab, as long as an accredited fertility lab, I think you'll never go wrong. And the reference that you need to look at, if you have a reference in front of you, it should be the 2021 semen analysis criteria. And if it's abnormal, don't straight away label the man has semen analysis abnormal. Don't label it's a male fertility problem, because any abnormal sperm report should be repeated. Just like any blood test, you know, you look at the patient, they're not pale, but the HB comes back as 4. You're not going to jump the gun and transfuse them. Similarly, you know, when a sperm analysis is reported as abnormal, they could be the first group here, totally absent of sperm. This is very likely a major issue, but again, repeat them within a week. But if there's any other abnormalities, within 4 weeks is a decent time to repeat the semen analysis. But when you get 2 abnormal semen analysis, it's already almost certain there is some form of male infertility issue there. So these are the one semen analysis that we used to do. We used to follow the WHO criteria in 2010, but in 2021, we have revised the criteria because there's a lot of changes in sperm parameters over the years because of aging, because of environmental, mainly because of environmental effect. that we will find that, not much changes, but the requirement to label a man with semen analysis as normal or abnormal has been revised. So if you look at 2021 criteria, it's so much easier. The number of sperms, how many of them are grade A, grade B movers. So if you don't do a semen analysis in a proper IVF lab, you don't get a very good report. Therefore, you're making a wrong judgment based on an inaccurate report. So always remember, send the semen analysis, probably about 100 and 150 ringgit. So, and it doesn't take much to do the sperm test. And it takes almost immediate, within an hour or two to get the report. So it's quick, it's immediate. You can actually get an immediate report on the same day to get a 1/2 of the fertility issue sorted, the male part. The second and third is related to female. So the female part, I always say 1, 2, 3. 1 is the male, 2 and 3 is the female. So the women might have hormonal issue or structural issue. So don't get so confused with a lot of labeling, PCOS, primary, failure, premature ovarian failure, some genetic like Turner syndrome or PID. So you're going into too deep. All you have to do, ask yourself is, do you think this person, the female partner, has hormonal issue or structural issue? Hormonal issue is so easy. Just have to do this basic 3-4 hormones on the top part and ovulation. So from there, you will know exactly what is the hormonal issue. If you see FSH and LH very raised, you know this woman is entering a menopause or perimenopausal. Chances are very, very slim unless we have a small window to refer them to IVF sooner. But if you look at thyroid and prolactin, it's immediate, Thyroid dysfunction or hyperprolactinemia also contributes to hormonal imbalance related to fertility. So if you've done these tests, you can pinpoint on one investigation, you can rule out many factors related to hormone. And of course, some women have high or low testosterone, and this is where the diagnosis is polycystic ovarian syndrome being done. Bear in mind, many a times, women with PCOS are wrongly diagnosed. They are being told you have polycystic ovarian syndrome just by look at them, they're slightly obese or overweight. They have irregular periods. They may have a little bit of raised testosterone, especially for the Malays and Indians, because they have higher testosterone receptors in the skin. Therefore, they have slightly higher facial presentation of facial hirsutism. Therefore, these women are labeled as PCOS, but you don't have a proper diagnosis based on a hormonal test. But when I see them in the clinic, sometimes they're actually premature ovarian failure. Or they are 1% of 40 women below 40 years old are entering what we call severe diminished reserve. And they're actually the other extreme of PCOS. PCOS, you have many eggs, whereas diminished egg reserve or perimenopausal, they have very, very low egg reserve. Totally two different problems. One has a very good prognosis, and the other have a very dim prognosis, So bear in mind, don't label or diagnose without actual diagnosis being done. Like PCOS, you should have a basic hormonal test, including thyroid and prolactin. So a simple history taking will give you 90% of the time, am I looking at hormonal issue? If someone do not have a regular cycle, more likely they would be having hormonal issue. It could be PCOS, it could be premature ovarian failure, but we are tuned towards hormonal issue. Whereas some women may have period pain, dysmenorrhea, dyspareunia, painful sexual intercourse, just pure pelvic pain not related to menses, or in the past might have had a surgery for fibroid removal or cyst removal. Automatically you are tuned to structural abnormality. So from hormonal abnormality, you might be thinking towards structural abnormality. What structural abnormalities could they be? Could be pelvic inflammatory, very common and commonly missed because they are very subtle symptoms, especially the younger generation now. They start to have sexual intercourse at a young age without any protection. By the time they go towards the reproductive age group, I think the damage has already been done. So pelvic inflammatory diseases, especially chlamydia, and Neisseria and VDRL, treponema infections are on the rise. So I think GPs are the commonly seen first-line doctors. They don't come to a gynecologist. They don't go to a dermatologist, but they come to a primary care physician. But whenever you're in doubt, take a very thorough history. If you're not sure, treat them empirically for PID. And the other common diseases commonly diagnosed late with the 8 to 10 years delay is endometriosis. If you ask any gynecologist, especially reproductive specialist, what is one disease that you think you would like to eradicate? I would say endometriosis. Worse than a cancer. Cancer, at least you have a diagnosis, you have an actual treatment. Endometriosis is just a progressive disease. It's just going to get worse from bad to worse. So if you have an early diagnosis, you have a lot of intervention to correct this disorder. And of course, the other thing is...
Can I ask you,
yeah,
how common is this endometriosis in women?
So if you look at the prevalence of endometriosis in the normal population, it's almost 60 to 70%. The prevalence.
So high.
It's so high. If I can tell every 1 of 2 women in reproductive age group will have endometriosis. The question is, when is the diagnosis done? Normally 8 to 10 years in delay. That's why it's a very subtle symptom. Sometimes they just present with epigastric discomfort during menses. They present with mild dysmenorrhea and often regarded as it's normal. Pain is normal. A period pain or pelvic pain is not normal. The moment we label them as normal, that's when we are disregarding a lot of early symptoms.
But at my age, right, we grew up to say that period pain is normal. And a lot of us have, maybe, yes, you're right, about 70% of my classmates or my uni mates had period pain. So did I. I mean, I had severe period pain to the extent that I may throw up during that time. But we just took it as normal.
Exactly. I think that's where now endometriosis is a month dedicated for endometriosis. There are a lot of women now coming out, and our awareness and our intervention is often delayed because we are labeling them as normal. That's why for me, I think forget about fertility treatment. If you can end up diagnosing endometriosis sooner than later, have all sorts of intervention at a primary care level sooner than later, I think we can, in a way, prevent endometriosis-related fertility issue. We should go into prevention rather than treating. Endometriosis is a preventable disease, in my opinion, if diagnosis is done much sooner.
I see. So I think it's very important for the GPs to pick this up and further investigate, or at least refer, right?
Correct. I think the problem with endometriosis, a lot of these times are diagnosed when they're stage 3, when you see a cyst in the ovary, because you can pick it up on a imaging. But the stage 1 and stage 2 are very subtle. You can't pick it up. Pain can be severe, but no signs. The interesting about endometriosis is nowadays you do not have to have interventional, like invasive procedures like laparoscopy. There's a new tool, very high sensitivity and specificity with saliva testing.
Saliva
testing. They have found a lot of biomarkers that you can even diagnose endometriosis. It's a qualitative diagnosis, meaning yes or no, just by saliva testing, yet to be introduced in Malaysia, but already in Europe. So once we get a CE and FDA approval, this is probably looking at 6 months to a year to be made available just by saliva testing.
I see. And what is the marker?
They have a lot of these chemical biomarkers that, just like CA125 is a blood marker.
That's right.
Similarly, now they have a lot of interleukins and all that is the cytokines that women with endometriosis secretes in their saliva.
Oh my God.
So they have identified this and they have done a genomic study on that, and their markers of this can be detected on a saliva testing. So that's where a lot of this research is going on towards non-invasive early diagnosis of endometriosis.
Okay, I think we will have to invite you back again when the saliva test is back.
No, I think that's very interesting.
Very interesting,
I was
extremely interesting.
That's very, very important, I think, because nowadays people are doing an invasive, laparoscopy should be reserved as a treatment rather than diagnostic.
Okay.
And a lot of primary care physicians could actually do a simple test, you can actually order a HSG to tubal patency test. Some of them are doing saline infusion, but I would say if you've not done it before, don't attempt it because it can be, have a small risk of introducing infection. But, ordering a HSG test just by, thinking, if this woman has been trying for a long time, I would like to rule out structural damage to the tube. Simply order a HSG done by the radiologist. Simple. The invasive type is the laparoscopy. That I would normally keep it as my later option. But the other thing that you should have at a primary care level, I think, is an ultrasound scan. Doesn't matter, whether it's a high-end or 3D scan, doesn't matter. Those were the days, even with a 2D scan, we can pick up simple mass. So if you have the cheapest ultrasound scan, get it. It doesn't matter. As long as you can pick up obvious signs like fibroids, adenomyosis, or ovarian cyst. I think we can't, in this era, I think all primary care physicians should have an ultrasound scan machine. Simple thing. Just 2 months ago, a patient was referred to me for a fibroid removal. A 45-year-old Indonesian lady from Medan referred for fibroid. She came for second opinion because the doctor said remove the whole uterus for a 43-year-old. She took the Medan, she took the flight, arrived in a Beacon, and was chaperoned for a potential case the next day. I just asked her a few questions. When was your last period? 3 months ago. No pregnancy test was done. Her last childbirth was 6 months, 6 years ago. She assumed the irregular menses that she had a few was because she's 43 years old. Just put the probe, it was a fetal, 12-week size fetus.
Oh my God.
So what they thought when they put the scan in, they thought the water around the baby, the fetus, the amniotic fluid, was the cyst. And the uterus, that the big bulge, was the fibroid. So if you've done, even with the ultrasound scan machine, people are making mistakes. But if you have a good clinical history taking, all amenorrhea is pregnancy until proven otherwise. That is the basics of anything, So if you have a simple test like this, I think in this era, even an ultrasound scan machine can make a mistake. So what more, So go back to the basic. Irregular menses, ask for a urine pregnancy test, and then, those kind of things. But I think primary care physicians should have an ultrasound machine. Fibroid, adenomyosis, ovarian cyst should be diagnosed sooner than later. Why should they come, fix an appointment in an expensive hospital, seen by a private gynecologist, just to tell them when they have a fibroid, which could be easily done at a primary care?
True.
So what can I do? If I'm a primary care physician, I'll be asking myself, what can I do? So I will just have these 3 checklists in my so-called writing pad. Ask yourself, what is the woman's age? If she's 40 years old, don't keep them too long in your center, in your practice, because you are wasting her time. Women's age is the most important factor for fertility. You can't do magic with their age. If I'm 35 years old, my window might be bigger, but when I'm 40 years old, my window is narrow. For some women, the window would have shut. What if the egg reserves are terribly low? You might actually tell a 40-year-old, don't ever bother doing fertility treatment, go for adoption. Or even for some women, egg donation is not acceptable. So they have no other option but for adoption. And this might come as a shock for them, thinking, the last 5 years, nobody mentioned that to me. So have a cutoff age, a female age. My advice, 38 years old and above, just get them going and do some tests, but keep them going towards a referral sooner than later. If they've been trying for more than 2 to 3 years, it's too long. 1 year is good enough. And if you already know that the patient has got hormonal issues, irregular menses, or do you think they may have structural issues, painful menses, you already suspect back of your mind, this has a gynecological issue, therefore let me do some test, So for men, there's no other test, You don't have to go and examine a man. Those were the days, they said abnormal sperm analysis, examine the man. Bullshit. You don't have to do anything. As long as the man has a sperm, he can father a child. The question would be, does this sperm enough to give you a pregnancy naturally, or this sperm needs IVF? Because end of the day, only one sperm that is needed. So men always gets it easy, unless they have azoospermia. So for men, all you have to do is just a simple sperm analysis, nothing more. And for women, my suggestion, get these 3 tests done in your place. AMH blood test, this is probably the one blood test that the most precious blood test I would tell everybody to do, even in your late teen years. You do not want to know you have a fertility problem when you're in your 30s. If I want to know, you want them to know in their 20s. Why? Because you don't go in life with fingers crossed, you want to know exactly, if I'm going to have a fertility issue at the age of 25, definitely it's going to be a bigger problem when I'm 35. So at 25, you have some options. You could freeze your eggs. Some people are doing ovarian tissue preservation, but that's a bit overkill. But I would say egg freezing, simple. That's one option. By doing a blood test for AMH, you can actually detect, is my window getting narrowed in the next couple of years? If your blood test says you have an excellent egg reserve, don't even bother, Go in life with very high level of confidence that you're going to have a good fertility window.
Okay,
Sometimes...
Can you please explain to me what the AMH stands for?
AMH stands for a hormone test called anti-Mullerian hormone. It actually a simple blood test taken at any time of the period, not necessarily day 1, day 2, or day 25.
What, during the period?
No, anytime of the cycle, even day 1 or end of the period. So it's a test that can be done randomly, regardless of the menses.
Not having period, can do.
Can do, correct.
Oh, okay.
So
anytime at all?
Anytime at all.
Okay.
At any age, as long as they already attain menarche. Okay. But normally we do, I would cut off at the age of 18, Okay. So that's probably where, teenage going into adulthood. So then you don't want to do a test at the immature, when they're teenagers, because they can't make decisions.
And that's right.
So I would say that gives you a number. It's like a passport, It tells you a quantity, a number. The higher, the better in terms of egg reserve.
I see.
So if you're, and it quantify, and it matches with the age, So a 40-year-old should have maybe around 10, but a 30-year-old with the number 10 is not a good number. So it tells you your ovarian aging, not your biological age, but your ovarian aging.
What does it test that it can be so accurate about the number of eggs that you have?
Because what they've done is they've seen AMH blood tests, and we do IVF, so we can roughly correlate the number of eggs that I'm going to get with the level of AMH. From there, we can do a deduction. The higher, the more eggs I can get. The more eggs I can get, the better my reserves.
So anti what again? Anti?
Mullerian, Mullerian, Mullerian hormone.
So this Mullerian hormone is produced by
the ovarian follicles.
I see.
So if I have more follicles, the higher my levels.
Okay.
The lower follicles.
This Mullerian hormone does what to a woman?
This Mullerian hormone is a quantitative assessment of your egg reserve.
Yeah, but as a hormone, it doesn't do.
It doesn't have any. It doesn't have any effect on the hormone in our physiology. It's only a quantity. Yeah.
Okay.
So it doesn't affect us in any way, but it's just a test that quantifies the egg, and that is the so-called gold standard for your ovarian reserve marker.
Okay. Mine would be 0 then.
Yeah, probably lower, because as we grow older, it goes into an undetectable level.
I don't even have ovaries. Okay, go on.
So, and don't forget your FSH, LH, and your prolactin, because these are the baseline hormones that you should have. Because sometimes you do an AMH blood test, it tells you the reserve. But when you do the FSH, LH, prolactin, and thyroid function, it gives you a wholesome hormonal profile that can affect fertility. A good example would be a patient with AMH blood test, AMH of 30, a very good number, but they may have FSH, LH in reserve. They might have high estrogen, and they might have polycystic ovarian syndrome. So it gives you a clue that this woman actually have a good reserve, but she also have a hormonal issue with PCOS. So it gives you a little bit more detailed information about the exact hormonal issue. Thyroid dysfunction, commonly missed, and they're very subtle, especially for women. So that's why if you're not sure, just do a simple TSH. That will tell you a lot of information about women. Women are more affected hormonally when it comes to thyroid dysfunction as compared to men. More autoimmune related disorders are among women. Therefore, thyroid dysfunction is one of the highest on the list. The last but not least, you can get a HIV, sorry, not HIC, but HIV, my type error there. Hepatitis B serology, hepatitis C, and VDRL. Why you need this is because, sexually transmitted diseases. You do not want your male partner to transmit this to the female partner and therefore make it, the whole risk of the fetus, unborn fetus, have a higher risk. 2, we know VDRL positive have a higher risk of carrying sexually transmitted diseases. So you're tuned to think about structural abnormality. So these are not magic tests that only a gynecologist would be able to do. I think as a primary care physician, you should be able to do this in the first instance, and you actually would be the first line person who decides, should I refer this patient now, or should I do something within my practice, at least not to waste their time. And they might get lucky, A lot of my colleagues in primary care, we do phone call just to have a quick information whether should I refer or should I just start treating in my place. A lot of good news, So that minimizes the patient's time. That minimizes my time. By the time they come and see us, referral, all the basic tests has been done. More on my side, I just have to make a decision, not further investigation. So you want to make fertility diagnosis of infertility at one stop, not multiple visits, then you're wasting your time and theirs. So this is where I think a primary care should be able to do and help themselves, to have all this information. What additional test, that you should be able to do, like I mentioned earlier, a pelvic ultrasound scan. If you can do an obstetric scan to look at the fetus, what else there, it's so difficult. Just make sure that you fill them up with a full bladder, do a tummy scan. If you're not sure whether it's a bladder or cyst, ask them to pass urine, repeat the scan. If it goes missing, it's the bladder. If it's still there, it's probably an ovarian cyst. So keep practicing, keep practicing. All women who comes to see you, just do a tummy scan, an abdominal scan. In 2 days' time, you would have done 20 scans. On the 3rd day, you're a pro, and can pick up pathology.
Yeah, true.
So I think, you don't have to go for masterclass in ultrasound scan. You do not have to hire a sonographer in your practice because it increases the cost, and they are not the person who's going to manage the patient, you. So sometimes the mind doesn't think when another person does the scan for you. So I think, this is what you see and what the mind thinks, you have to align it. And I think you should be able to do an ultrasound scan in your practice.
And then
What
with
are you looking
YouTube
for?
and Google, you can always look at the pictures. It's
Exactly.
a lot to learn from that.
Correct. I mean, nowadays with all these apps, it's a lot of apps, you can just go, bedside ultrasound scan. I see a lot of people. I picked it up when I was a MO, but I keep on doing all the scans when patient comes to the hospital because, that's when you can pick it up. But again, in GP practice, just do a free ultrasound scan or run a limited pelvic ultrasound free scanning, and then, in a month's time, you'll be good. Patients will come. So it's a win-win situation for both. And what are you assessing on this ultrasound? Of course, you want to pick up shadows. When you don't see any, chances are they don't have any problem. But the moment you pick up something small, start looking at it, Fibroids, very difficult to miss. Cyst, very easy to see. Polyps, a little bit difficult unless you've been trained to look at it. But, if you miss a polyp, it's forgiven. But you should not be missing out a fibroids or even a uterine mass,
A fetus.
Exactly, yeah, a fetus, and So see, this is a simple ultrasound scan, even for someone lay person who have never seen a proper ultrasound image, they can pick it up, black shadows like this. These are not normal. These are typical pockets of shadows. You're not sure, it could be bowel, but if you refer to a sonographer, or you can even refer to a radiology department to do a detailed scan, or even a colleague of yours, a gynecologist, you can confirm it. It's better to pick up things like this. Far right, this is a typical fibroids. Could also represent an adenomyosis, but this is beyond you, Don't have to worry. As long as you can pick up a shadow, this person has some issue, stop treating them, start referring them. Male investigation, so it's just a simple pictorial representation. It must be done before any further investigation on the females. Always remember that. Do not refer a female or start doing a lot of things on them until you have done a sperm analysis. That's one, must be in your fingertips, Do not simply order a lot of things, When you see a woman, you order HSG and all that, suddenly you find out the man has no sperm. A good example would be a simple test should be done first. Complicated test a bit later. So sperm is a simple test. So it is a must before further investigation. Like I said initially, it's a simple test, but do it with a certified lab, preferably an IVF lab. So if you look at that, you can see 3 parameters they look at, but the most important is the count. If you don't have a good count, don't bother with the morphology or the motility. So there's a marker, like I told you earlier, refer to the WHO 2021 reference range. What I suggest not to be performed at primary care. I think a lot of primary care physicians now, thanks to, kind of Dr. Betty running this platform like this, actually expose them to probably, all sorts of, they are, master of everything,
No,
they know
that's
everything
not
about surgery.
true. Don't blame me.
No, you are exposing a lot of GPs to all this, for breast cancer awareness, surgery, gynecology. I think now we can say most of these primary care physicians should be able to manage primary fertility or secondary fertility at a primary care level as for simple testing. No such thing, they should be referred immediately, because
True.
it is redundant to refer someone for an expensive test when it could be just simply ordered at a primary care level. But my main concern is time is crucial, A lot of these women spend a lot of time in the hospital spending money, because fertility is not covered by insurance. So they spend a lot of unnecessary tests, thousands of ringgit, just to find out something simple. So I would say, don't perform these things at the primary care, HSG, just refer to Beacon Hospital, for example, because that's where, I practice, and that's a commonest, this one, but not necessarily must be Beacon, I might be wrong here to say Beacon, but it's just that when I present in seminars related to Beacon, of course, I mentioned, but if you have a hospital that you're comfortable working, just refer to the radiology department, not to the gynecologist. Because HSG is a radiological imaging. Make sure that you refer them. And lap and dye, normally we do as a gynecology surgery, it's a minor surgery. But always make sure that the need for tubal patency will be decided after a fertility review. For example, I told you, if the man has major sperm problem, don't bother testing the tubes. Because whether the tube is patent or not, the pregnancy rates are 0 in severe semen abnormality. So some tests doesn't need to be done, But what I suggest, what GPs, primary care, must have for fertility services, I think, folic acid, why must be, this is for preconceptionally, it's proven. And if you're not sure, just make sure, you have this so-called standard practice in your in your GP practice. All women thinking about getting pregnant should be on some form of folic acid. How you give it, whether you give it in a supplement form or you're giving in a combination of multivitamins, this is something that you should be employing very early on, not when they are referred to a gynecologist. And always remember, don't prescribe contraception. This is common mistake, Yesterday, a patient came in with PCOS. She was on birth control pill because her doctor she presented with fertility problem, but she was having irregular period. So the doctor said, go on birth control pill. So it will regulate your period. And she was trying for 7 months. Of course, you'll get zero pregnancy because you already put on birth control pills. So it regulates the period, but it makes you inability to conceive. So always remember, when you want to put someone for fertility, make sure you don't put them on birth control pills. You put them on ovulation induction medication, because ovulation induction improves ovulation, regulates the menses, and at the same time gives you a chance to fall pregnant, but not contraception, not birth control pill. And ideal BMI, this is where I think a lot of people are going towards now. A lot of primary care physician is doing like a holistic kind of medicine, bioidentical hormone intervention, weight loss programs. Nowadays, we have this oral medication, injectable magic, so-called magic medication. And if you look at Ozempic, if you look at a lot of publication now, they say Ozempic increases fertility among women. It does not increase the fertility among women. It just reduces the weight. Therefore, your ovulation induction becomes improved. So by weight management, your ovulation improves. Therefore, your fertility improves. It does not increase the fertility. It just improves your weight, and therefore your fertility indirectly improves. So all this medication could be done even at a primary care level. I think lifestyle modification, probably you are better than most gynecologists because you know the patient well, you know where they stay, you know their lifestyle, you know what kind of work they do. So you would be probably the best person to engage a dietitian, or you engage a lifestyle modification or weight loss program for them. I think those are the things that you should be doing. And I think good to scan it abdominally. Like I mentioned earlier, you should be doing ultrasound scan per abdomen. Vaginal ultrasound a little bit tricky, but not tummy ultrasound scan. Abdomen. Offer basic blood tests. All of you have access to biochemistry laboratory. Use them. Do a simple AMH blood test. Not sure, just do it. You'll never go wrong. Because it gives you a lot of information. Even endometriosis you could diagnose earlier. If a young woman with low egg reserve, you'll be thinking, is she having endometriosis, and therefore that's why the reserves are low. So it gives you an opportunity to further investigate what else could there be wrong with this person at a very early stage. So do ovarian reserve testing earlier and sooner in your practice. Semen analysis, like I mentioned, referral to an IVF lab, not a biochemistry lab. And within your unit, I'm not sure how your referral pathway in your clinic works. But what I suggest is have a dedicated doctor that you can speak to over the phone. Just like those days, when we were medical officers, we call our specialists, and they can make a decision over the phone. And now you have that access, with phone, with WhatsApp. Have a group, have a comfortable group that you can cross-refer. And this is not about, a lot of people look at this as a financial, commercial gain. Don't look at the commercial gain at all. When you have a very good referral system with a right personnel in, I think you're giving your patient the right access, and you're minimizing their burden. So I feel like, in my opinion, I feel like it's less patient that I see probably will benefit the patients more, because when I see less patient, sometimes I get a better result. For a good example, we have a few GPs in our group. By the moment they refer to us, we know already what next step for the patient. The patient will feel so relaxed. One stop, diagnosis done, straight into the treatment, and no time loss. Those were the days you see a patient with fertility 10, 15 years. A good example, a couple of months ago, I saw a 37-year-old lady, 12 years of subfertility. A big problem was actually endometrial polyp. She was seen by a couple of physicians, keep on doing ovulation induction. All we have to do was just an hysteroscopy. And 2 months later, natural pregnancy. I did an IUI, she didn't fall pregnant. Then we thought, okay, let's buy some time, she fall pregnant naturally. That just tells us, that 12 years was a big waste, but lucky she was 37 years old, So those kind of things, So in our ecosystem, I think there's no such thing as, who the patient's going to see more, who's going to patients. No, the patient have to see the right person, the sooner the better. So let's have your own ecosystem.
Can you
Phone
hear?
call away.
Okay.
And what GP can start, yes, can they start treatment? I would say yes. You're never gonna be wrong if you start a treatment soon. Nobody gonna care and say, hey, you're not ethical, or they say you've done something wrong. Nobody can say that, because when you start someone on clomiphene or even letrozole, but limit yourself to 3 cycles, because there's a small theoretical risk prolonging clomiphene treatment beyond 6 months, have a small theoretical risk of ovarian cancer. Theoretical, but not practical, but so limit it to 3 months or 3 cycles with all letrozole. Feel free if you want to know what's the dosage, when to start, because normally I have a small patient information. So what I do, I just give it to the patient and tell them, go and try yourself 3 months with letrozole or clomiphene, or sometimes we snapshot and just give it to some of our GP friends so that they have it in their clinic and automatically they can employ this in their initial practice. Metformin, if you have a diagnosis of PCOS confirmed, metformin and myo-inositol, these are the 2 so-called medication that improves fertility, improves their diabetic control, improves risk of miscarriages, and the dosage is 500 milligram TDS or 850 BD. And the current thought process is myo-inositol is like a vitamin B derivative, not a typical vitamin B, but a sub isomer, a different type of vitamin B that works beautifully and superior to metformin with almost 0 side effects. So you could even get this in your clinic. You could employ that as your first line treatment once you've seen a polycystic ovarian syndrome attempting to get pregnant. Weight loss programs, like I mentioned, you can do what you think is right within your practice, whether it's oral, Ribelsus, I think it's a newer oral drugs, and there's injectable. I have very minimal experience with it because I'm not a big fan of medication when it comes to weight loss. I'm more typically old time, but I think you have to work towards something. There's no such thing as an easy ticket to fertility, because discipline is all about this. But some patients really need this, those who are type 2 diabetic, early onset of diabetes, they have joint disorders, they can't run, these are the patients that may be a good candidate for this, and only you will know better. Dietitian, physical programs are all within your own in your clinic. When to refer, I think this is my last slide. I think you should have a simple referral checklist, 35 regardless of duration. Don't keep them too long. If you want to extend, 38 years old, but make sure you have an AMH blood test. Anyone trying to conceive more than a year, don't waste your time, don't waste their time. If the semen analysis is abnormal, like I told you, if 2 semen analysis is abnormal, nothing much we would want to do. We do not want to waste their time. They might be a good candidate for early referral. But if you think they have a history of gynecological surgery, multiple laparotomy, multiple laparoscopic surgery to the ovary or to the uterus, already a candidate for structural abnormality, get an early referral. And last but not least, anxious couple. This is very difficult to gauge anxiety. There's no marker, this is level 3, level 2, level 4, but you can gauge, if someone is, having fertility issues and is good enough, strong enough to affect their interpersonal relationship. I know some of them may already have, undergoing some counseling. You would know them, by talking to them, you would know whether this couple's fertility issues affecting them. Get them referred sooner than later, because sometimes, in my practice, sometimes I'm half counselor, going through their, sexual practices, not having enough sex, loss of libido, third party involvement because of one party is not interested. Sometimes it's just no physical or pathological issues with them. It's all more emotional. So I think, if you have it, refer them sooner. with that, I end my talk. I know it's not easy to listen because it's easier to talk, and talking is not an art. Listening is a more of a difficult art, and I appreciate the time that you spend. It's 9 to 10 o'clock. Thank you very much for your time.
Okay, we have a lot of questions that were coming in while you were talking, which is quite amazing because usually they come much later. And Dr.
Yeah.
Ong Gilin asked, if the hormonal test come back as normal, the next step, do we proceed with hysterosalpingo?
I think if the sperm test is normal, because that's the first test you're going to do, the hormone test comes back as normal, especially if you have a reassuring AMH. So if you're not sure, you must have a good AMH report. Anything more than 10 is considered within okay. Anything beyond 20, probably they have PCOS. But if you have a good AMH, normal hormone test, and the sperms are normal, go ahead and do HSG. I would do it because sperms are normal, regular cycles, could be a tubal factor.
No, the other day I saw a patient
do it.
came in to see me because she told me she wanted to get a cardiac assessment before she conceived. Okay.
Yeah.
But actually, she has been trying to conceive, and she's in the mid-30s, not old.
Young, yeah.
And I asked her a simple question: how often are you having sex? And she said, only when the thermometer is showing that it's the right time. I'm like, what? And that's like once a month.
Correct.
So how do you get pregnant?
I mean, we can't just go to Genting Highlands, you pull the slot machine, you're going to win, You have to spend time there, keep on pulling the slot machine. Same with sex, You can't just have once a month and hoping to be lucky, But what we deem as a normal attempt at a pregnancy is 2 to 3 times a week.
I would think so.
Yeah. Yeah. And a lot of people always say, I want to do my ovulation test, but it's a retrospective information because your body temperature goes up after ovulation. Even if you're doing the LH kit, the urine kit, sometimes you miss by a couple of hours and the egg would have died. The egg doesn't have a long vitality. Within probably 12 to 14 hours, it is not good enough. So that's why we always say must have sex before you ovulate, not after ovulation. You can have multiple sexual intercourse in a day. After ovulation, no point. You should have the sperms waiting for the egg, not the other way around. So a good attempt should be 2 to 3 times a week. But with the current digital era, with a lot of these things, I mean, people are having less sex. Those were the days when they can't wait to get married to have sex, or they have sex before marriage. But now is the time they get married and they're trying to think, can I just have sex once and get a baby? No, so I can't, it becomes a chore, it becomes a physical sexual activity, becomes a anxious and a physical emotional stress for many couples.
Oh, it's
So
very
I would always
weird.
tell them, if that is an issue, that it's already an anxious couple, that's going to affect them, and they are taking away their own chances.
Okay, we go on with the question first. Dr. Yalan asked, how about the timing of taking the hormonal blood investigations? It is said to take day 3 FSH, LH, day 21 progesterone. Is it true? And how to determine it in a person who have irregular menses or amenorrhea more than 3 months? Good question, I think.
This is probably one of the good questions.
Yeah.
I tell everybody, 2 to 3 months amenorrhea or irregular cycles. Amenorrhea is total absence of period. So when you have oligomenorrhea, irregularity within the last couple of months, you already know they got a hormonal issue. You don't have to think about it. You can confirm this is a hormonal issue. The question is it PCOS? Is it hypothyroid? Is it prolactin? So you do an amenorrhea study, standard. Do an amenorrhea study. That's one. So the typical day 21 progesterone is not applicable anymore. Stop doing those tests. It doesn't tell you much. So if you were to do one good test, I would say do an amenorrhea study and an AMH test. That will give you the right information on egg reserve and also type of hormonal issue they have.
Okay, can I
Yeah.
ask you, for example, in this case where the patient already have irregular menses and or amenorrhea, and you suspect that the patient has hormonal issues, do you still ask the husband to send for sperm?
Oh, yes, definitely. That's why I said
Always, is it?
always make sure, because 50% of problems are male related. So what if the man also has a low sperm count? Then it becomes a combined problem. Therefore, your treatment will be slightly different, because if not, you start putting a pressure on women and you start doing so much, and yet if they don't get pregnant, you are labeling indirectly it's a woman's problem.
Okay. So sorry, I've never done obstetric or gynecology as a doctor before. Dr. Felicia asks, I want to ask a question. If a woman has a period of less than 28 days, will it affect their egg reserve or their menopausal age?
I mean, typically a standard textbook description of a normal regular cycle would be 21 days to 35 days. Anything in between is still considered normal range. It's just that we take the midpoint, a 28-day cycle, and then we tell them, oh, if you're 28-day cycle, no. Some women can be 22 days, some may be 34 days, but that's normal for that particular woman. But if anyone with a shorter cycle or longer cycle, you're always worried of hormonal issue. The one with a shorter cycle, you're worried whether they are have a low egg reserve. A lot of women go through a shorter cycle before they reach their menopause. So I'm always worried with short cycles. The longer cycles are normally like polycystic ovarian syndrome, and they have good egg reserve. So when you're not sure, if it falls out of this range, out of 21 to 35 days, do an AMH, do an amenorrhea study. You would have already zoomed in, Don't do any other test. Amenorrhea study and an AMH. You'll be 99% of the time, what's wrong.
Okay, Dr. Santoso asks, what can we do for a patient with low AMH, or how to increase their AMH?
I mean, this is a golden question. If I could do that, probably I'll be one of the best fertility specialists. But unfortunately, there's no way that we can improve an egg reserve, because egg reserve is something that you're born with. Women are born with the highest number of eggs when they are fetus. From 12, 13 million, it drops down to a couple of million, 3 to 4 million at your puberty. So that's the time you reach your first menarche, the first period, you have the maximum number of eggs, and it just declines as we grow older. So there's no way of reversing our ovarian aging. But what we can do to these women is to minimize the potential damage to the eggs. That's where a lot of people are talking about supplements, vitamin D, CoQ10, DHEA. But, they are not magic drugs, So they might do very minimal improvement in your AMH. So the short answer to low reserve is quickly go and get a pregnancy. You might need IVF sooner than later. 2, there's a smaller intervention now, where what we are doing now is like an ovarian PRP, injecting ovarian platelet-rich plasma into the ovary. It's a very new concept, and we are also employing stem cell, mesenchymal stem cells injection into the ovary with the intention of reactivation dormant follicles. A very novel therapeutic intervention. Good evidence, strong evidence are coming up, and these are all last resort, to do that. But when you see low reserve, quickly go towards fertility treatment.
Can I ask you, if obesity is getting rampant?
Very common, 55% in our practice, women are overweight.
Yeah, women, and more so women than men, actually. And they're getting overweight younger and younger.
Very true.
So when they are overweight at the teenage years, will it actually affect their future fertility?
I think fertility, being overweight does not make your egg reserve goes down, put it that way. So your egg reserve is something that is preserved. It only gets damaged by endometriosis, radiotherapy, repeated surgeries on the ovary, chemotherapy, or sometimes it's just some people are born with some genetic autoimmune disorders, for example. But weight reduction or excessive weight gain or excessive weight loss does not improve the AMH, but they affect the quality of the eggs. So for an age match, 25 years old obese women and a 25 years old normal BMI, the women with 25 years old obese women have almost half their eggs very poor quality.
I see.
Numbers might be the same, but the quality very much affected.
Oh, very okay. So the numbers are the same, yeah. So Dr. Ong Gilin asks again, what are the cyst size or number indicated for referral?
The ovarian cyst, unfortunately, there's no one cutoff. For example, you may have a small cyst, 3 centimeter, but it could be an endometriotic cyst. It's a small cyst, but it's an endometriotic cyst. So I would not have a cutoff, but if I see persistently there's a follicle, there's a cystic nature in the ovary for the 3 cycles, repeated 3 cycles, I know this is a pathological cyst. A functional cyst, for example, a corpus luteum or a simple cyst, we call it follicular cyst, they would disappear over time. A persistent cyst over the last 3 months, if you see them persistent and they don't disappear, 3 centimeters or more, probably need some attention.
Okay, Dr. Jalita, oh, nice name, Jalita. Okay, can apple cider vinegar help female fertility?
Unfortunately, I have not much information on that. The intervention with some dietary. I suppose it might, but I'm sorry.
It's to
I
drink,
know
right?
not much.
It's to drink, right? Not to
It's
like
a cider drink, yeah, cider drink. But what it may have is antioxidants. So a lot of women are talking about this taking antioxidants. That's where this CoQ10, high doses of vitamin C, certain fruits, certain berries, acai berry, for example, a lot of these Usana products, a lot of these so-called natural organic products contains a lot of antioxidants. We typically believe that if there's a antioxidant imbalances, it will affect the egg quality. But bear in mind, we need oxidative damage and antioxidative at a balance, So if you take too much antioxidant, you actually is tilting the balance. Just because you're taking so much of good antioxidant doesn't mean your egg quality will be good. So you're actually, in a way, damaging the balance. So if you're a smoker, probably it helps. But if you're a good weight, you're a healthy lifestyle, I don't think you need to add on too much to it.
Okay, Dr. Shaswani asked, do we need to regulate cycle first if it's irregular cycle?
Sorry?
Okay,
do you need to regulate the
cycle first if it's irregular cycle?
Oh, good question. You need to regulate the cycle with an ovulation induction agent. Because the reason they might not be having a regular cycle is because they are not ovulating. Therefore, your treatment should be towards ovulating, not regulating the cycle with the birth control pill. Because the moment you regulate the cycle with birth control pill, you're artificially creating a period, but you're not growing eggs. So you have to regulate the periods with an ovulation induction without the use of contraceptive pills.
Why do women have eggs but do not ovulate?
Because you do not have the balance of the correct balance of ovulation induction. For example, your FSH should go up.
Okay, I understand.
And then the egg should be growing, and then the LH triggers the ovulation. Most women do not have the balance because there's a lot of antagonist hormone. For PCOS, for example, you have FSH, but you have a high level of testosterone. Therefore, it suppresses your FSH from stimulating your eggs. So when the balance is tilted, you do not have the eggs growing, but you have the eggs there, but they stay dormant.
So in PCOS, right, a lot of women are overweight.
Many overweight. There are also lean PCOS. The typical lean PCOS, the Chinese type, are mainly lean PCOS. The Malay and Indians, majority of them are overweight PCOS.
Okay, Isa said my prolactin level now is normal range after cabergoline.
Cabergoline, hyperprolactinemia.
But
the medical
I still
treatment is
can't conceive. HSG and sperm are all normal.
I think very difficult for me to say whether it's normal or not, but if I can see the sperm test, it's normal and the tubes are not blocked, and now you have regular so-called ovulation. I think the next step is to go and consider, do you fall in this category called unexplained? Because about small group of women have ovulation, patent tubes, normal sperm, and still not get pregnant. This is a group we call unexplained subfertility. So these are the couple that may benefit sooner with a little bit of injectables or IUI treatment.
Oh, okay. What is an what is amenorrhea study?
Oh, amenorrhea study is basically a group of tests that we do for women with irregular menses or those who totally doesn't have a period. It consists of 5 hormone testing: FSH, LH, thyroid, prolactin, and testosterone. So most of the laboratory like InnoQuest, Gribble, those is InnoQuest, Path Lab, they have this column called amenorrhea study. You can just tick it off, but basically it gives you these 5 common hormones that affects the menstrual cycle.
Okay, we have a question from Facebook. Shafika Shahira asks, can metformin and inositol be taken together for PCOS?
Oh, definitely can be taken, I think it's synergistic effect. It's just that if patient might have, a lot of women don't like metformin because it makes a lot of GI disturbances. But if you can tolerate, even better, because in a way, metformin also suppress your appetite for the overweight ones. It might help. Yeah, and it also brings down your insulin level. Therefore, the hyperinsulinemia, helps in bringing down the antagonistic hormone. But myoinositol works slightly different, so they both combined definitely have a better effect than what in using only one. But in the end, it's a side effect profile that turns off a lot of women on metformin.
Okay, Gurpreet asks, if ovarian cyst is 3 cm, is that necessary to do a lab cholecystectomy?
Lab cholecystectomy?
I think it's too random. You need to see the morphology, the age of the patient, and many things, right?
For what is this? I didn't get the question, sorry.
Okay, wait, I ask again. If ovarian cyst 3 cm, is it necessary to do lab cyst?
No, I think it's overkill, but it just gives you a little bit of information. Am I dealing with endometriosis? Because this patient might have an endometriotic cyst at 3 centimeter, but at the same time, she might have a tubal factor, but endometriosis can also damages the tube. So it just gives a little bit of information rather than not having the but I wouldn't solely go in and remove the cyst because sometimes the damage risk is higher. So the recommendation is any cyst below 5 centimeter, if possible, if it's endometriotic, don't operate. But the moment it's 3 centimeter, you just have to keep a close watch whether it has a tubal blockage or not. So it gives you a little bit more surveillance on this patient. You do not want to miss them. At the same time, you don't want to keep them in your follow-up 6 months, 1 year without doing anything. You might act faster. Maybe you can do a tubal testing. Maybe you can consider IUI. If not, you might have to go for IVF. But just because you're doing IUI or IVF, any cyst below 3-4 centimeter, try not to do surgery. The damage risk is higher.
Okay, is there a trend of delaying age of marriage as a common cause of infertility nowadays?
I think if you look at 2010 and 2021 data of Malaysian statistics, our total fertility rate from 2 has dropped to 1.6. The total fertility rate is our replacement. 2 is what every country should have for the younger generation to replace the older one. So the moment it goes below 2, I think all the countries now is below 2. Very few countries above 2 or there. Ours is 1.6. So it says that our fertility rate is indirect marker of infertility. But the bigger portion is women are starting family. I'm not sure whether they're getting married later, but starting to consider starting family at a later age. They might have got married in their early 30s, but typically 5 or 6 years later thinking about starting the family. 2, a lot of these women now I mean, all of us, career, we can't say now women are career, all are equal now. So women are also in the same corporate structure where, they want to delay their childbearing to a later date so they can, to concentrate on their career. That is the bigger worries, If you delay your childbearing and deferring it in your mid-30s, that's a big mistake. You can do that if you have a good egg reserve. So my advice to most women is get an AMH test done. If it's low, preserve your fertility, freeze your eggs or freeze an embryo, and then go ahead, chase your dreams, and come back in your late 30s or 40s and see whether you can get pregnant or not. If you can't, you still have embryos frozen. But
My
once you miss that
life has
opportunity,
become so difficult. So in this era where we talk about infertility and so many people are infertile,
yeah,
is birth control still a policy to have?
I think yes and no, because when you look at the population that is infertile, probably looking at 15%, 85% might need some form of contraception, because they have no fertility issue. But the problem is that our diagnosis, I think we are not aware. Just like health screening, why are we doing diabetic screening, but we're not doing fertility screening? Because if you know you're diabetic at the age of 30, you can prevent multi-organ failure. You can prevent multi-organ effect. But if I knew my fertility at 20, I could even avoid my infertility in my 30s. One simple test for women and one simple test for men will screen your fertility. Why are we waiting? That's my question to most couples now.
No,
Be a
because
bit more proactive. Just because you're single doesn't mean you can't empower yourself with the fertility information about yourself.
but the decision is a little bit more difficult. For example, in the
Yeah.
20s, and
Yep.
I feel like I want to go all out and I'm not keen on marriage, but I want to preserve my egg. It is not that easy. How much does it cost to preserve an egg? Okay.
See, this is where I think everybody gets it wrong, because everybody thinks if I want to preserve my fertility, it has to be egg freezing. No,
Okay.
if I want to preserve my fertility, first thing I need to know, what is my egg reserve? If my egg reserve is reassuring for my age, 20 for a 20-year-old, it's good. Therefore, you can tell, I'll come back in 2 years' time and see how my fertility is dropping or not. If it's dropping, then I might be thinking, do I have endometriosis? Maybe at that time, I can take some birth control pill and see whether I can minimize or control or minimize the damage of endometriosis, because a lot of these women actually have underlying issues. Not about going straight and preserve my fertility when I'm just 25 years old.
I feel like if you
So
you
we have to
talk about this,
empower.
if you know your egg reserve,
Yeah.
the decision is still not that easy. It's like, okay, it's dropping. I need to find a man. It's just odd. You know what I mean?
But you'll be surprised. Most women, they are not they are not planning to have a baby at that time, and they don't have partners. But most of the time, they'll come to you for various reasons. They might come to you for irregular periods and so on. So these women don't see you for fertility issue. They see you for purely gynecological issue.
Okay,
so yeah, so we tune them towards protecting their gynecological health by preserving any intervention. Could it be birth control pill? Could be some medication for endometriosis. If they have the financial means, if they want to preserve the eggs, that is an option, but we do not want to present that option too early, because it becomes commercialization.
Okay.
In that case, you're scaring young women to go and freeze eggs. I think that's wrong.
Okay. Okay, Dr. Grace.
So I mean, I will do AMH for all women. The test is slightly expensive, about 200, 300 ringgit. But if I can get it done at a cheaper, I would get it done as soon, for all women, the moment they go for 20 years old or more.
Okay, Dr. Greeker asked, can women in their 40s still store egg cells? And how long can the egg cells be stored? And are the quality still good?
Good question. In our center, the average age of women coming for egg freezing is about 38.9, almost 39 years old. Ideally, 35 or less. But in reality, how many 35-year-old will be thinking, I want to have a baby now, and shall I wait? But reality hits you when you're late 30s. I'm already 38, 39. The last 5 years I have not met my Mr. Right. And if I were to have a baby in my 40s, this is probably my last, last curve, Therefore, yeah, a lot of them come in their late 30s, early 40s, but not necessarily you must preserve your eggs. You can do an AMH blood test first. If you have a very good egg reserve, then it's worth freezing the eggs. If I can preserve about 10, 15 eggs for a 40-year-old, that's a good number. But if your AMH is only 2, 3, or 4, I would tell them don't bother freezing your eggs, because you're not doing, justice to yourself by preserving 2 or 3 eggs. And in reality, it doesn't going to give you a good chance of having a baby later. So yes, you can do it, provided you have good egg reserve. Some women have excellent egg reserve, 40-year-old, but very poor uterus. So that's why, sometimes you have to look at them in the whole picture, Must have a good uterus, good ovary, and a simple ultrasound scan can give you everything. That's why if you have one blood test AMH, it gives the women a lot of information.
Okay, I think our take-home message is actually one, to do AMH, and then we from there can counsel women.
Correct. Yep.
Okay, not just on fertility or infertility, but
Very
also
true.
yeah.
I think we're not talking about fertility, we're talking about egg reserve.
Yeah.
It's an individual human right to know what's their egg reserve at a younger age, just like doing pap smear. You're doing pap smear to know whether there's a risk of having a cancer in future. Why can't you just do an egg reserve to know? Because in America now, infertility is being labeled equal to cancer because the emotional cost is as equal as a cancer emotional cost to women. Not to men, but to women. So what justice are we doing if you can't even do a simple test and giving them all the right information?
Can I ask you, is infertility treatment covered by insurance?
No, yes and no. In Australia, yes, the Medicare covers for it, but in Malaysia, no insurance covers except for few corporate. Meta covers 3 cycles of IVF, Google covers, and some oil and gas companies. So we have patients who come in and do multiple egg freezing because they are like for Facebook or Meta, they cover 3 cycles. So a lot of these corporate women in their late 30s, early 40s come 3 cycles because it's paid by their company for women. That's why I see now more and more so-called women's benefit is being gauged whether they cover for fertility or for single women to freeze their eggs.
Can I ask
So
you, if the low sperm count is genetic?
Yes and no. Many men who have poor semen analysis may have Y chromosome abnormality. So that's why sometimes we have to do karyotyping. Some men are born with Klinefelter syndrome, Y chromosome microdeletions. But I don't like to do too many genetic testing because for men, as long as we can find sperm, we always tell them, don't bother. We know you can be a father of this child because we have enough sperm to get a baby. This genetic testing, chromosomal testing is more for academic purposes. But yes, very small percentage are genetic.
I see. Okay, I think we have to close the session now. I'm so it's been an amazing session. I think we have to bring you back to speak more because there's too many questions. Dr. Gi, Dr. Ong Gi-ling, I'm so sorry. I won't take your question anymore because I think that the IVF is just one whole chapter by itself. So yeah, maybe next year because I have webinars until end of this year all filled up. So thank you so much, Mathi.
Thank you very much, Dr. Betty, and thank you everyone, for your attention.
I think it's been a
Thanks
very good, productive thing, and I think I learn a lot, and I think the GPs should start thinking about the AMH, right? Yes.
Yes.
Yes, and women out there because this is also stream live to public. So yeah, consider doing an AMH, know your rights, okay, and know your eggs. Okay, see you then. Bye,
Thank
Mathi.
you. Good
Thank
night.
you so
Good night,
much.
everyone.
Bye-bye. Thanks.